Hello, and thank you for joining today's virtual educational program with Cancer Support Community Los Angeles. I am Larissa Montalvo, and I welcome you to this week's webinar titled Cancer Disparities in the LGBTQ+ Community. Today, we are joined by Mayra Serrano from the Center of Community Alliance for Research and Education at City of Hope to explore how cancer impacts LGBTQ+ communities. Mayra will discuss how the LGBTQ+ community is disproportionately affected by cancer and the importance of screening and early detection. But before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch past webinars, please visit our website at www.cancersupportla.org. Without further ado, I would like to welcome today's speaker. Mayra Serrano is the manager at the Center of Community Alliance for Research and Education at City of Hope. Her work focuses on partnering with community advocates and multi-sectoral partners to develop and implement community participatory programs and interventions to reduce the risk and burden of chronic illnesses, including cancer. She develops, plans, and implements health education programs targeting underserved populations and conducts health disparities research. Mayra received her master's in public health and community health sciences from UCLA and is a certified health education specialist and medical interpreter. She is currently pursuing her Doctor of Public Health degree at UNC Chapel Hill. Welcome, Mayra.
Thank you, Larissa. Thank you for having me today, and welcome everybody. So we'll go ahead and get started. I'm going to start sharing my screen. So thank you for joining us here today. And our topic today is going to talk about cancer health disparities in the LGBTQ+ community. So for those of you who don't know what cancer disparities are, this is a definition by Healthy People 2020. Health disparities basically is these differences that are linked to social, economic, and environmental disadvantages, right? So what happens in a health disparity is that certain groups are adversely affected. And it's usually because they have greater obstacles to health based either on their racial or ethnic group, their religion, their socioeconomic status, their gender, their age, their mental health, physical disability, sexual orientation, or gender identity. So that's really what a health disparity is that just when specific groups are disproportionately affected by a certain condition. And for today's talk, the focus is on cancer. And so I added this here. It's the acronym LGBTQ+, for some of you who might not know what the LGBTQ means. So this, I kind of like this image because it explains what all of the letters mean. So that you can be familiar with it. And then let's talk a little bit about the LGBTQ community. And I made it specific to our community here. In California, we know that there's over 1.6 million individuals that identify as LGBTQI+ in California. And the most interesting part of that is that the majority are in Southern California. 57% of those people live in Southern California. And we know that LGBTQI+ individuals really have these unique healthcare needs, right? But studies have reported that over half of the LGBTQI individuals report experiencing discrimination in care. And as a result, 1/3 of them have not shared their gender identity or sexual orientation with their healthcare providers. So that's important to note. So we all know that the data that I'm going to give you sometimes might not be as accurate because we're not very good, number one, at collecting the data. And so not everybody, asked for this information. But from what we do know, we know that LGBTQ people report a lower well-being in 5 areas specifically. We know financial security, physical health, a sense of purpose, social life, and community attachment. They did report lower well-being in those areas. And we also know there's a minority stress. We know that same-sex individuals are 2 times as likely as heterosexuals to have experienced discrimination in their lifetime. We know they're also 5 times more likely to indicate that discrimination interfered with having a full and productive life. And they're perceived in actual discrimination actually correlates with mental disorders. And then you have the intersectionality of being, an LGBT or QI plus community member, and if you're also a racial or ethnic minority. So you have racial microaggressions that are found to predict various types of physical health conditions, right? Like general health problems, pain, lower energy levels, and fatigue. And we also know that it can also result in symptoms of anxiety, depression, and burnout, and actually even higher cortisol levels, which is the stress hormone. And that's just from the stress of this. And then we also know that there's a lot of fear and concerns about accessing healthcare, right? This is giving you some data. The blue is showing you LGB, the green is showing you transgender, and then the gray is showing you those living with HIV. And so here you see that the transgender persons will report high numbers of thinking of this perception that they will be refused medical care, that they will be treated differently by medical professionals, that there's not enough health professionals adequately trained to care for people who are LGBTQI+. There's not enough support groups, there's not enough substance abuse treatment, and that there's a community fear, dislike of people who are LGBTQ, and that is a problem. We also know from other studies that LGBT clients report that providers at times have used excessive precautions or refused to touch them. So in one study, 11% of the respondents said that. They also oftentimes, 12% of the respondents said that doctors blame them for their health status. 11% even reported that their medical professionals have used harsh or even abusive language. And then transgender patients report, 25% of them report being harassed in a doctor's office, and 19% reported being denied medical care. And of course, this is all completely unacceptable. A little bit of information on some more disparities. We know that 24% of bisexuals lack health insurance versus 20% of heterosexuals. We know that men who have sex with men represent 2% of the US population, but account for 56% of the people with HIV and 66% of new HIV infections. We know that 40% of homeless youth are LGBT. We know that 39% of transgender people have faced harassment or discrimination when seeking routine health care. We also know that 26% of bisexual women reported suicidality. And we know that men who have sex with men are 17 times more likely to develop anal cancer than heterosexual men. And we're going to go into details of those cancers. But I wanted you to have a background on how it's not just health related, but it has a lot to do with stigma. It has to do a lot with what we call the social determinants of health. So here is just a quick snapshot of things that we're going to talk a little bit more about. Here we see that lesbian and bisexual women report poor overall physical health. We know that lesbian and bisexual women report a heightened risk for and diagnosis of some cancers and higher rates of cardiovascular disease. Gay men are also at higher risk of HIV and other STDs, especially among communities of color, and higher rates of certain cancers. And we also know that bisexual women are more likely to be uninsured, overweight, and obese, and as well as lesbian women as well. And then we know that trans women, particularly women of color, have significantly higher prevalence of HIV and STDs. There's higher rates of violence, mental health issues, and suicide. They're also less likely to have health insurance and access to transgender compensating care than heterosexuals or LGB individuals. And when it comes to cancer survivors, LGBTQ cancer survivors are more likely than their heterosexual peers to report depression or anxiety. They're more likely to use drugs or alcohol and less likely to exercise. And then we even see disparities at end of life care. So a typical scenario would be let's see that we have a dying patient that's LGBTQ, and they may find an estranged family member making decisions about palliative care, health interventions, and who should receive information on the patient's care. Or sometimes we might see transgender patients that they fear that they will be buried with their dead names or as their gender that was assigned at birth. So those are things we see as well. But as I mentioned, there's these social determinants at play here. There's social stigma, there's rejection by family members, there's abuse and violence, there's unfair treatment in the legal system, both state and federal. The stress that comes from hiding some or all of your aspects of one's life, the lack of health insurance, as I mentioned, they're more likely to be uninsured. And then the shortage of culturally competent healthcare providers. And we know that in the research shows that LGBT people found that stigma and discrimination are associated with taking more sick days, experiencing a serious physical health problem, HIV risk behavior, and delaying needed urgent and preventive care, which is why we have to address all of these issues. And I had mentioned discrimination, right? So you have marginalization, feeling invisible, fear and anxiety, shame and guilt, oppression, and violations of civil liberties. And that creates that minority stress that then contributes to these health disparities. Even though being LGBT is not genetically or biologically hazardous, this stigmatization and marginalization, regardless of whether an individual identifies as lesbian, gay, bisexual, or transgender, are really the primary reasons for these health disparities in the LGBTQI plus community. So it's really the sexual behavior, not sexual orientation, also that determines STD and STI risk. And other kinds of risk may be specific to identity rather than the behavior. But again, it's mostly based on this. So let's talk a little bit about some of the details of how some of our LGBT peers are affected by cancer. So when it comes to lesbian and bisexual women in cancer, they have an increased risk for breast cancer. That's often because they experience fewer pregnancies. Bisexual women are twice as likely, and lesbian women are twice as likely to have never given birth compared to heterosexual women. And they're also most likely of the LGBT demographic to have never had a mammogram and Pap test, right? So then that puts you at risk as well. The fact that they're not getting screened, the fact that there's a higher prevalence of obesity, breast cancer, it's a huge risk factor, especially in postmenopausal women. And increased alcohol use as well, and puts you at higher risk of developing breast cancer. Now, when it comes to pregnancies, it's that having children, especially before the age of 35, and breastfeeding are actually protective factors, and they lower your risk of getting breast cancer. There's also an increased risk of cervical cancer. And this happens because a lot of times lesbian and bisexual women aren't getting Pap test. As I mentioned, they're very less likely to take a Pap test. And even though many lesbians have had or will have male sexual partners, that puts them at risk for HPV, which we'll discuss later, which can lead to cervical cancer. And then we also know that HPV can also be transmitted through sharing toys that have not been properly cleaned. So a lot of women might think, well, I'm not having sex with men, I don't have to have a Pap test, but it's still very important to get a Pap test. There's also an increased risk of ovarian and endometrial cancer. Again, that's related to the decreased number of pregnancies. It's due to a decreased use of oral contraceptives, because in this case, using oral contraceptives is actually protective and reduces your risk of ovarian and endometrial cancer. And also the increased tobacco use. We know that in the LGBTQ community, tobacco rates are actually double the California rates. And we'll go into that in a little more detail as well. And again, all of these are really risks that are made worse because of delayed diagnosis, because of not getting screened, whether that's because people lack access to care, because people don't have a culturally competent healthcare provider. The provider maybe doesn't bring it up as well. So but that usually is the underlying cause. And then when it comes to, again, to cigarette smoking, the data suggests that lesbians smoke cigarettes at a substantially higher rate than heterosexual women. And then some research reports higher rates of heavy drinking among lesbians than in heterosexual women. And then in some reports, we see that lesbians are more likely to be overweight or have a BMI over 25. And again, lesbians are less likely to have biological children before age 30, which would offer some protection. But the most important thing here is that lesbians and bisexual women report lower rates of mammography, colonoscopy, Pap smears than their heterosexual counterparts. And again, this could be due to a combination of limited financial access, being perception of being unwelcome, or having lesbians and bisexual women are also less likely to have adequate health insurance coverage than heterosexual women, leading to these increased risks. Now let's talk about men who have sex with men in cancer. Studies have shown that gay men are at risk and sometimes increased risk for several cancers, including prostate, testicular, and colorectal. And gay men may be at risk for death of these and other types of cancers because of access to screening services may be negatively impacted because of issues and challenges in receiving that culturally sensitive care. Gay and bisexual Black men have the lowest use of PSA test, which is a prostate-specific antigen test. It's a form of prostate cancer screening compared to every other group of men. Gay or bisexual men also reported more frequent indoor tanning and higher rates of skin cancer than heterosexual men. Again, the other thing that we found that in areas with a higher concentration of bisexual men had a higher incidence of colorectal cancer. In areas with a higher concentration of bisexual women had a higher incidence of lung and colorectal. Now, we don't know because this is just correlation isn't causation. But again, sometimes we can't get a lot of the data because the data isn't being collected, and we really need to be better at collecting that data so we can know more of this information. Now, here's a little data on transgender people and cancer. Transgender people have extremely high rates of smoking, drinking, and HIV, and this increases the risk of developing an array of cancers, including lung cancer, anal cancer, liver cancer, non-Hodgkin's lymphoma. And we also know that estrogen is believed to influence the development of some types of cancers, including breast, ovaries, and the lining of the uterus. And sometimes the risk of cancer may be increased for trans women who have taken estrogen over a long period of time. We don't know this for sure because we do need to collect more data. And we also don't know whether trans men taking high doses of testosterone are at an increased risk for estrogen-dependent cancers. Because we know that there's a naturally occurring enzyme, aromatase, that converts some testosterone to estrogen in trans men. So we really need to develop more research to make sure to find this out. Again, not enough research has been done to know whether trans people get cancer more than non-trans people. But there are concerns, right? Because there's the association between social economic marginalization and cancer. We know that higher rates of cigarette smoking and alcohol consumption is related to cancer, and we know it's higher in trans people. We know the risk for sexually transmitted infections can be linked to cancer, right? Like HPV and hepatitis. The long-term impact of hormone use, again, we don't know that yet. And additionally, there's the lack of inclusive information in medical care means that trans people are not benefiting from cancer prevention services. And we know that transgender people face the greatest barriers to quality healthcare, coupled with very little research on cancer risk and experiences. And they often face frequent discrimination by healthcare providers, many of whom also lack information about trans bodies and healthcare needs. So let's dive into HPV and cancer. And that's something we focus on a lot at City of Hope and my team. We know that HPV causes over 35,000 cancers every year. And it's associated with cancer of the cervical cancer, vaginal cancer, vulvar cancer, penile cancer, anal cancer, rectal cancer, and cancer of the head and neck, so oropharynx, oral cancers. And the oropharynx includes the back of the throat, including the base of your tongue and your tonsils. So cervical cancer is actually the most common HPV-associated cancer among women. You have over 14,000 cases diagnosed each year, and over 4,000 women will die. And it's mostly diagnosed in women between the ages of 35 and 44. The average age is about 50. About 20 cases that are in women over 65. And then cervical precancer is diagnosed far more often than invasive cervical cancer, and those numbers are not included here. Cervical cancer used to be the leading cause of cancer death for women in the US, but in the past 40 years, the number of cases of cervical cancer and the number of deaths have decreased significantly. Why is that? It's because of the Pap test. Getting regular Pap tests, it can find cervical cancer before it's cancer, when it's pre-cancer. It actually prevents cancer. Very few screenings prevent cancer, but the Pap test is one of them. It can actually prevent it. So in recent years, too, we have the HPV test that's been approved as another screening test for cervical cancer, because we know that most cervical cancers are due to HPV. And the HPV test looks for infection of high-risk types of HPV that are most likely to cause cervical cancer. The HPV test can be used alone or at the same time as a Pap test. And cervical cancer is the most frequently diagnosed in women between the ages of 35 and 44 again. So it's mostly younger women. So what about cervical cancer in lesbian bisexual women? The cervical cancer can affect any woman who is or has been sexually active with a man or a woman, because HPV is a sexually transmitted infection, and it's one of the most common infections. 4 out of 5 people have had HPV in their lifetime. And we know that cervical cancer is caused by it, and it's spread to skin contact. You do not need penetration for HPV to be transmitted. So for that reason, this includes female to female sex. And you can also get it from genital to genital, oral to genital, or digital to genital contact, or from sharing toys. Also, some lesbians may have either had sex with men at some time in their life, currently have sex with men, or have partners who have had sex with men and women. So that's why it's important for lesbian bisexual women to be screened. Now, the rates of cervical abnormalities are similar from lesbian bisexual women to heterosexual women. And abnormalities have been found by Pap smears, even in women who reported no sexual history with men. So even if you've never had a relationship with a man or sex with a man, you could still be at risk. Now, lesbian and bisexual women are 10 times less likely to undergo the regular screening. So they're less likely to have a Pap test. And as I mentioned, it's very important to have a Pap test because that's what prevents cancer. And then lesbians are less likely to access preventive care compared to other women. And both lesbians and bisexual women are less likely to be insured compared to other women, which could be one of the reasons why they're not getting Pap tests. Now, cervical cancer in trans men, the majority of trans men do not undergo complete gender-affirming surgery, and they still retain their cervix if a total hysterectomy is not performed. So trans men with a cervix should follow the cervical cancer screening guidelines. If the cervix is completely removed and there was no prior history of high-grade cervical dysplasia or cervical cancer, then no Pap tests are necessary. So, and that's because cancers of the female reproductive organs are still possible in trans men. And cervical cancer has been documented in male transgender patients. Pap test, again, it can be difficult for trans men for a number of reasons, including, the lack of knowledge that they may still have their cervix, maybe their doctor not being culturally competent or not asking or not bringing it up or offering. The other cancer that's associated with HPV is, like I mentioned, oropharyngeal, and 70% of these cancers are associated with HPV. Men are more affected by this than women. And the population, how many HPV positive cancers has increased 225%. And if the trend continues, actually, and it did continue, and oral cancers now surpass cervical cancers as the number 1 HPV associated cancer. Before, oral cancers used to be connected to tobacco or alcohol use, but now most of them are identified as HPV related cancers. So a little bit of the signs and symptoms of oral cancer, because there is no screening for this. So hopefully you go to your dentist every 6 months as it's recommended, because sometimes they can catch it early. Having a sore throat or ear pain that doesn't go away, constant coughing, pain or trouble swallowing or breathing, weight loss, hoarseness or voice changes that last more than 2 weeks, or a lump or mass in your neck could all be signs and symptoms. Now let's talk a little bit about anal cancer. 90% of anal cancer are associated with HPV infection. Every year, 2 out of every 100,000 people are diagnosed with anal cancer. HIV negative men who have sex with men are 20 times more likely to be diagnosed with anal cancer. So that's about 40 per 100,000. Now, HIV positive men who have sex with men are 40 times more likely to be diagnosed with anal cancer. That's about 80 cases per 100,000. Now, anal cancer is caused by the same strains of the HPV virus that cause cervical cancer in women. In the general population, anal cancer is a rare disease. Very few people even know about it until maybe Farrah Fawcett made it public, made her struggle public. But among men who have sex with men, the incidence of anal cancer is significantly more prevalent and increasing every year. We know that HPV-related anal cancer rates in men have significantly increased in the past 30 years. And HPV types 16 and 18 are most frequently the types associated with anal cancer. The problem here is that the majority of men who have sex with men know really little about this disease. They've never been tested for it, or they even know that a screening exists for this. Same thing with healthcare professionals. They remain divided on how and whether to screen for it. In fact, there's no standardized screening protocol for anal cancer. It doesn't exist yet, hopefully. And among heterosexual women, the vast majority of infections are cleared naturally by the body within a few years. Usually by the time we're 30, we cleared the infection, we fought it off. But for some reason that we don't know yet, it's less true for men who have sex with men, where the infections are often still present in later adulthood. Again, not all HPV infections lead to cancer. Some of us fight it off, some of us don't. We still don't know what that difference is, but we're looking into it. Now, what are the signs and symptoms? Sometimes there aren't any, unfortunately, but anal bleeding, pain, itching, and discharge. It could be swollen lymph nodes in the anal or groin area. If you have changes in your bowel habits or the shape of your stool, or there's sores around the anus that don't heal, those could all be symptoms. But there's an anal Pap test. Pap test can be used to test for anal cancer and precancerous cells, just like it does for a cervical Pap test. Some physicians recommend that men who have sex with men, especially those that are HIV positive, be tested every 1 to 3 years. If you're HIV negative, you can be tested every 3 years. But the best form of prevention for anal cancer is the HPV vaccine. Now, some physicians don't believe that the routine screening of men who have sex with men is needed. They really cite that there's a small number of positive cases, the shortage of facilities to follow up procedures, and that there could be a lot of fear, cost, and pain involved in pursuing these small changes that are called dysplasias. And most importantly, too, a lot of health insurance policies don't cover anal Pap smears. But we know that current research from the Fred Hutchinson Cancer Research Center has found that not only does HIV infection increase the risk of HPV infection, but that the converse is true. HPV enhances the susceptibility to HIV infection. And this could happen because the anal HPV lesions make the surface of the tissue of the anus thinner and more vulnerable to the entry of the HIV virus. And additionally, the immune cells activated by HPV infection are precisely the ones more vulnerable to HIV infection. So this data really increases the value of HPV screening in men who have sex with men. So we really want you to speak to your doctor about this. Now, in a survey that we did, most men had never had a Pap test. 65% had never had one. And even almost 16% didn't even know. They weren't sure. They didn't know what it was. So what are the health problems caused by HPV? So most of the men who get HPV never develop symptoms. or health problems. Like I said, we fight it off. Some types of HPV can cause genital warts. Other can cause cancer of the penis, anus, and oral. The types of HPV that cause genital warts are not the same that cause cancer. And anal cancer is not the same as colorectal cancer. Colorectal cancer is more common than anal, but it is not caused by HPV. So we know that about 1% of sexually active men in the US have genital warts at any one time. We know that cancer of the penis, anus, and oral pharynx are uncommon, and only a subset of them are related to HPV. But 400 men get HPV-related cancer of the penis. About 1,500 men will get HPV-related cancer of the anus. About 5,600 men who get cancers of the oral pharynx. But many of these cancers are related to tobacco and alcohol use, not HPV. We also know that some men are more likely to develop HPV-related disease than others. So gay and bisexual men are 17 times more likely to develop anal cancer than men who only have sex with women. Men with weakened immune systems, including those with HIV, are more likely than other men to develop anal cancer. Men with HIV are also more likely to get severe cases of genital warts that are harder to treat. And an estimated 61% of HIV negative and 93% of HIV positive gay and bisexual men have anal HPV infections. Again, an infection doesn't necessarily mean cancer. And that's compared to only 50% or less of heterosexual men. Now, I mentioned there was an HPV test for women, right? We talked about that. You can get it by itself or you can get it with a Pap smear. Now, unfortunately, there's no HPV test recommended for men. The only approved HPV tests on the market are screening women for cervical cancer. They are not useful for screening HPV-related cancers or genital warts in men. So screening, and as I mentioned, screening for anal cancer is not routinely recommended. And this is because more research is needed to find out if it can actually prevent anal cancer. But as I mentioned, some experts do recommend yearly anal cancer screening for gay, bisexual, and HIV positive men, since anal cancer is more common in these men. Now, as I mentioned, in most cases, people with HPV have no symptoms, but they can still pass on the virus to others. We know that research suggests that over half of men who have sex with men have anal HPV infections, and about 17% have an oral HPV infection. And we know that these rates have increased recently. And the rates don't decrease with age like HPV rates for women do. So the older we get as women, the lower our rates of HPV. But in men, that's not the case. They do not decrease with age. So what are the different types of HPV-related cancers that men who have sex with men are at risk for? They're at risk of anal cancers because HPV causes 90% of anal cancers in this group. They cause 70% of the oral cancers and 50% of the penile cancers. Now, I did talk a little bit about anal HPV and men who have sex with men is higher than the cervical HPV and dysplasia among women, in that it doesn't decrease with age. In one study in Seattle at Fred Hutch, 70% of the men who have sex with men aged 16 to 30 had an anal HPV infection, and 37% of the participants were infected with HPV 16 and 18. And other studies found similar higher rates of risk in anal HPV types among men who have sex with men. And high-risk oral HPV infections have been detected in approximately 15% of men who have sex with men, and about the same number in high-risk penile HPV infections. So HIV-positive men are at increased risk for HPV infection and anal cancer. As I mentioned, HIV-positive men who have sex with men have higher rates of high-risk HPV infection than those who are HIV negative. And we know some reports have found that over half of the HIV-positive men who have sex with men had an HPV anal infection with an HPV type that causes cancer. So maybe that's 16 or 18. In another study, HIV-positive men who have sex with men had 65% had high-risk anal HPV and 32% had high-risk penile HPV. And HIV-positive individuals are up to 28 times more likely than HIV-negative individuals to develop anal cancer. So how do you lower your chances of getting HPV? The answer is to get vaccinated. HPV vaccine is safe and effective. Get screened, so get a Pap test and ask your doctor. Use latex condoms. If used with every sex act from start to finish, it may lower your chances of passing HPV to a partner or to develop HPV-related diseases. But again, HPV is skin-to-skin contact. So the HPV can affect areas that are not covered by a condom, so condoms may not fully protect you from HPV. We also recommend dental dams and latex glove can also help cover infected areas to reduce the risk of transmission. Because HPV is so common and it's usually invisible, the only sure way to prevent it is not to have sexual. So, and even people who with only one lifetime sex partner can get HPV if their partner was infected with HPV. So again, the HPV vaccine can really help. If you're 45 or younger, there's an HPV vaccine that can help protect against the types of HPV that most commonly cause problems. And the HPV vaccine works by preventing 9 common HPV types. It protects against new HPV infections. It doesn't cure existing infections or diseases like genital warts. It's not going to cure you, but it's going to prevent you from getting future infections. And it's really the most effective when a person, before a person's first sexual contact. So that's why it's recommended when you're younger. Because in your first sexual contact, you may be exposed to HPV. So right now, we really recommend the HPV vaccines for ages 11 to 12. Teens and young adults to the age of 26 who didn't start or finish HPV vaccine also need it. The vaccine is also recommended for gay and bisexual men or any man who has sex with men and men with compromised immune systems, including HIV, through the age of 26, if they did not get fully vaccinated when they were younger. Now, the vaccine has been approved by the FDA for everyone through the age of 45, but it is most effective when you're younger. So a total of 3 vaccines have been licensed by the FDA, but there's only one currently available because it replaced the others. So there's one called Gardasil 9, and it actually protects you against 9 different types of HPV, and it replaced Gardasil because that only protects you from 4. And there was another one called Cervarix, which only protected you from 2. So Gardasil 9 is the one that's available now. So this is what is recommended. You can have 2 doses of the vaccine if you're between the ages of 9 and 14. If you're 15 to 26, you're going to have 3 doses. If you're a male between the ages of 21 and 26, it's again a 3-dose regimen. And if you're 27 to 45, it's FDA approved, but it's not currently recommended. Now, I'm going to tell you a little bit about a study we did at City of Hope with our partners in the Latinx Task Force. We did a cancer needs assessment. And as a result of this survey, we wanted to see what the cancer needs were of the LGBTQ community. And we really discovered that there's a growing need for LGBTQI plus culturally competency trainings in order to create welcoming and respectful healthcare environments for LGBTQI individuals. So, and I'm going to show you some of that data, but I wanted to let you know as a result of this data, we were actually able to develop a 1-hour training presentation to increase the awareness about the importance of gender identity, pronouns, and using inclusive language to build these welcoming healthcare environments for members of our LGBTQI plus community. So this is the data that we found. We found that not everybody shares their gender identity or sexual orientation with their doctors or healthcare providers. I mean, the majority did. 44% said that they shared it with all of their doctors. 36% said they shared it with some, and almost 17% said they shared it with none of them. Now, bisexual and pansexuals were the ones who were less likely to share their gender identity or sexual orientation with their providers. Gay men were more likely to share their gender identity with their healthcare providers. Now, this is the one that's most troubling to me. Have you ever been afraid to share your gender identity or sexual orientation with your healthcare provider? So you can see the numbers here. The options were always, often, sometimes, rarely, or never. Now, if we add up those who said always, often, sometimes, and even rarely, unfortunately, that means that 73% have at one point or another been afraid to share their gender identity or sexual orientation with their healthcare providers. And this is completely unacceptable. We need to create more welcoming and inclusive environments so that people aren't afraid to share this information. Now, the people who were more likely to state that they've been afraid were those who identified as queer. And those who, yes, I'm sorry, I was reading the wrong line. But yes, so those who identified as queer were actually the ones who were more likely to be afraid to share this information. Now let's look at the testing. So we also asked about screening behaviors. And here, out of those that were eligible, so the responses were yes, no, not sure, I don't have a cervix, because we didn't select this based on gender identity, because we know that that doesn't necessarily mean you don't have a cervix. But of those that were eligible between the ages of 21 and 29, 60% have not had a Pap test in that age range. So that is huge. So as I mentioned, that's why we have disproportionate rates of cervical cancer. And those who were more likely to report that they did have it were cisgender females, were bisexual. And so that means that lesbian women were less likely to have the Pap test in this age range. Now, in the age range of 30 to 64, they did have a Pap test. The majority, 67, had a Pap test, but we're still nowhere near the numbers we're supposed to be. Numbers should be in the 80s, 90s, percentage of people getting, because again, this is a screening that prevents cancer. Now, for mammograms, of those, we asked those who were over 40 if they had had a mammogram. And again, we added here, I don't have breast as an option because we didn't self-select by gender. 50% had not had a mammogram. And those who were less likely to say they didn't have a mammogram identified as bisexual. So this is really important. So half of these people are not getting the screening. And we know that screening saves lives, early detection, because we can find the cancer when it's still small and treatable and curable. Now, for colonoscopy, the numbers were a little better. About 64% of those 50 and over said that they did get a colonoscopy. But we want this number to be at 80%. That's where we want our numbers to be. Now, another question that we asked is, we asked if they've ever received LGBTQI tailored cancer information. And no surprise here, 91% said that no, they had never received anything that was tailored to them, for them. Again, this is unacceptable. We need to be creating more cancer information that's tailored to the LGBTQ community. Now, we also asked about behaviors that put you at higher risk for cancer, and we know that alcohol is one of them. We asked if they had ever had 3 or more alcoholic drinks in one day. And as you can see, 69% of them said yes. Those who were more likely to have 3 or more drinks a day were cisgender men and those who identified as gay. So they were more likely to have more alcohol use. We asked if they had smoked or used smokeless tobacco. The answer here was 20. Again, that's double the rate in California. The current smoking rate in California is 10.1%. And those who were more likely to have smoked in the last 30 days were trans women. We also asked if they ate 5 or more servings of fruits and vegetables a day, because that's what we're supposed to have about 5 to 9 servings a day. I think I have 2 down so far, so I got 3 more to go today. And that, again, most of them, 68% said no, that they were not consuming the recommended amount of fruits and vegetables a day. And again, in the US, only 33% of adults eat the recommended serving. So it's not too different, for the LGBTQ community. So we're doing bad in both areas. So we all need to eat more fruits and vegetables. Now, what about exercise? Do you get at least 150 minutes of moderate exercise each week? That's the recommended weekly amount. It's about 30 minutes most days of the week. This was actually better. About 60% said yes. I mean, we could be better than that. Now, those who were more likely to get the 150 minutes were cisgender males and those who identified as gay. Now, this is another troubling statistic. When we asked if they were regularly exposed to UV rays, either the sun, sun lamps, tanning booths, we had 48% say yes. In the US, that number is usually 33% of adults are exposed to these UV rays. So again, this is unacceptable. Skin cancer is something we can prevent if we don't tan in the sun, don't use tanning booths, and this number is really high. So the reason we asked all these questions because we wanted to know how we don't want to just create programs for LGBTQ communities. So we want to make sure we're addressing the needs of that community. And so we asking them, what is it that you need? What is it that you're doing so that we know how to develop our programs? From this, I know that we have to definitely have to talk about skin cancer and UV exposure. We need to talk about tobacco. We need to talk about eating healthy fruits and vegetables. We also need to promote mammography, Pap testing, colonoscopy. We need to promote all the screenings. So that being said, let's talk a little bit about the screenings. So the breast cancer guidelines, if you're 20 to 39 years old, it's recommended that you have a monthly breast self-exam, and this little picture is telling you what you should be looking for. And then a clinical breast exam by a trained healthcare professional every 1 to 3 years. And it's usually when you do your Pap that they do this, your annual physical. If you're over 40, you also need a monthly breast self-exam and the yearly clinical breast exam. But in addition, you need mammograms. So according to the American Cancer Society, if you're between the ages of 40 and 44, you have the choice to start annual breast cancer screening with mammograms. Now, the recommendation now is 45 to 54 that you get mammograms every year. If you're 55 and older, you can switch to every 2 years, or you can continue going every year. Screening can continue as long as the woman is in good health and is expected to live 10 or more years or longer. But they really want all women to know the benefits. Now, these guidelines are for women who have no history, who are not at higher risk. I started my mammograms at 35 because my mom had a lump removed at 45. So you need to know your family history so you can determine your risk so you know when you should start. I still do annual mammograms. But again, I started at 35, 10 years younger than my mom. For cervical cancer, it starts at the age of 21, regardless of onset of sexual activity, again, because it's skin to skin. If you're 21 through 29, you can have a Pap test every 3 years. If you're 30 to 65, you can be screened every 5 years. If you have the Pap test with HPV test. If you're only doing the Pap test alone, then it's every 3 years. Now, in the Pap test, they're collecting cells from the surface of your cervix. They're looking for any abnormal cells. And if they do find abnormal cells, they can actually treat it before cervical cancer develops. So when cancer is detected earlier, it is easier to treat. Testicular cancer. So testicular cancer is usually found as a result of symptoms a person is having. So most of the times men find it themselves. It's the most common cancer in men at 15 to 35. It can be detected through a self-exam or a physical exam. So this is showing you here how you can actually check yourself for testicular cancer. You can do it in the shower with a warm shower because we know there's no better way to say this, but there's hangage when there's heat, right? Because you want the testicles away from your body. We know when it's cold, the testicles get closer to your body because they respond based on temperature, but you kind of want them away. And then you just use your finger and your thumb and your 2 fingers and feel around to see if you find any lumps. So just like women do breast self-exams, men should be doing testicular self-exams. Prostate cancer. For this, men should talk to their healthcare professional to determine your risk. So there's been changes here. So we want the discussion to begin at age 50 if you're at average risk of getting prostate cancer. Now, if you're at higher risk, we want you to start that talk at 45. This includes African-American men, men who have a first-degree relative, that's a parent, child, or sibling, diagnosed with prostate cancer at a younger age. And we want you to start at 40 if you're at even higher risk, if you have more than one first-degree relative who's had prostate cancer. My dad had to start young because of my grandpa. So after the discussion, men who want to be screened should be tested with a blood test. It's called a prostate-specific antigen, PSA test, and a digital rectal exam. If no cancer is found the time between future screenings is determined by the results of that blood test. If it's less than 2.5, you may only need to be retested every 2 years. And screening should be done yearly for men if your PSA level is higher than 2.5. Now for colorectal, this is new. Now the age is 45. You need to start screening at 45 and continue until you're 75. You can be screened through either stool tests. And these are tests that check your stool for blood that can only be seen through a microscope. So you usually get a piece of paper and then you smear your stool on it and send it into a lab. This can be done every year, or you can have a colonoscopy. The colonoscopy is, aside from the Pap test, is the only other screening that prevents cancer. Because just like the Pap test, it can find pre-cancer and remove it. You can treat it before it becomes cancer. The colonoscopy is going to look inside your rectum and it's going to look at the whole colon. It really uses this thin tube-like instrument with a lens and a light to view inside of it. And then the doctors can remove any polyps, which is pre-cancer. And it can be done every 10 years if your polyps are found. Again, this is if you're not at high risk, you don't have any symptoms. I started my colonoscopies at 40 because at 50, my dad had polyps removed. He didn't have colorectal cancer, but just the fact that he had polyps puts him at high risk, which then puts me at high risk. So I had to start 10 years younger. So I had my colonoscopy at 40. So I am good for 10 years because no polyps for me. My mom, same thing, no polyps for her. My dad goes every 3 to 5 years because they found polyps. So he is checked more often. I did have an uncle pass away from colorectal cancer. So we are very careful from that. I've had an aunt pass away from breast cancer. Breast cancer runs in my family. So we're very vigilant about that as well. Now, skin cancer is the other one. This one is done through a check. You go to your dermatologist, but you can also keep your eye on this, right? If you can find it early, when it's small and it has not spread, it's easier to treat. They might just remove it. My aunt just had it removed from her cheek. She didn't even need chemo. They kind of just froze it and removed it. Now, for skin cancer, you need to remember A, B, C, D. So A means asymmetry. If you cut the mole or the spot in half, do the two halves look alike? If they don't, that's a bad sign. Look at the border. Is it irregular? Are the edges ragged and blurry like this one in the picture? That's not a good sign either. Look at the color. Does it vary from one area to another? If it does, that's not a good sign. D is diameter. Is it bigger than the end of a pencil eraser? If it's smaller, you're okay. If it's bigger, that's not. And then E is evolving. Did it change? Did a mole or skin lesion look different from the rest? Or is it changing in size, shape, or color? I've had 2 moles removed from the dermatologist. One looked like a Y in the back of my thigh. I did tell the dermatologist, if there's one part of my body that never sees the sun are my thighs. I'm not a big shorts wearer, but she removed it anyways. And then my lower back, she removed another one that she just said, oh, it's a little odd shape. I mean, luckily they weren't cancer, but it was quick. It was in the office. She just removed it. And I just had to come home and take care of it with some Vaseline, but quick and easy. Then lung cancer screening, it's the number 1 cause of cancer death, but now there's a screening available and it's available to those who are 55 to 80 years old. If you're currently a smoke or quit smoking in the last 15 years, you're eligible. If you smoked 30-pack years or more, that means you had 15 years of smoking, 2 packs a day. That's a 30-pack year. It's a low-dose CT scan and it's covered by insurance if you're eligible. It should be repeated every year, and it's really recommended for those who are at high risk. Now, we also developed, I mentioned to you as a task force that we worked in the LGBT cancer needs assessment. We did this one that was specifically for the LGBTQ community, because as you remember, they reported saying that there was no cancer information out that was tailored for them. So here we talk about eating smart, moving more, avoiding tobacco, limiting alcohol, practicing safe sex, avoid tanning, and getting vaccinated. And then we show how often, at what ages it's recommended to get the screening, and hopefully people fill this out. So this is something we pass out at events and at health fairs. When we go to Pride events, we pass these out. And then for that study, if you're interested in giving us more information, we'd love to collect more. This is the group of the organizations that participate in this survey. If you scan the QR code, it will send you to the survey. But again, as I mentioned, there's not enough data for us to be able to develop programs, which is why we're collecting data. So the more data we have, the more we can develop programs. So if you're interested in answering some of those questions, feel free. We have it in English and in Spanish. It's available. But if also if you are uninsured and don't have any resources for screening, the Every Woman Counts program, it provides free breast and cervical cancer screening and treatment, whether you're documented or not. So it's a great program. You can give them your zip code, and it actually gives you the provider closest to you. Planned Parenthood also provides the breast and cervical cancer screening and treatment program, and also provide HPV vaccination. You also have the LA LGBT Center who provides services. But if you want to learn more about, LGBT communities and cancer, these are great resources. And I will be sharing this PowerPoint with Larissa. But that being said, here's my email if anybody has any questions. But for now, I'll go ahead and stop, and we can take questions.
Thank you so much, Mayra. That was so incredibly informative and such imperative information. We're so happy to be hosting you, not just for Pride Month, but in general. And as I give you a moment here to put some questions in the Q&A feature, just a reminder that this is being recorded and will be up on our website within a month or so. You can also watch it immediately following this on Facebook Live if you join our Facebook at Cancer Support Committee Los Angeles. We have other resources for the LGBTQ plus community as well. We have 2 support groups, one for gay men with prostate cancer, and we have another for seniors with cancer within the LGBTQ plus community. So if you're interested in either of those, head on over to our website or feel free to send us an email at info@cancersupportla.org. So I see we have one question here for you, Mayra, to begin. Someone is asking, why are those in the LGBTQ plus community more likely to be uninsured?
Yeah, so there's several reasons that can happen. So one of them could be maybe with employers. So if you're a lot of times, for example, my husband is covered through my insurance because he's my husband. But oftentimes, if your employer doesn't cover partners, then you don't have access to insurance, right? So that could be the case as well. It could be also, there's a lot of LGBTQ community in the service area industry, and a lot of the service industry, because they're not full-time employees, might not offer that insurance. So you have that. So there's multiple components that could lead to the fact that they're uninsured. We also know that, as I mentioned, you have youth that are homeless, so then they're not covered under their parents any longer. So it's multiple factors that can lead to that. But we definitely need to find a way to make sure that everybody's insured, or at least have access to care. That's a great question.
Yeah, that is extremely important. We all should have access to care. But Myra, I will ask you, according to your research, you've shown that a lot of people have trouble identifying themselves to their healthcare providers. Do you have any advice to give on how to feel more comfortable or how to approach the subject?
Yeah, so what you can do also, you can look up providers that are trained in LGBTQI healthcare. So the Health Equality Index exists, and that rates healthcare providers in terms of their ability to provide welcoming and inclusive environments for the LGBTQ community. For example, City of Hope is actually rated by the Health Equality Index. And I can't remember the website, but you can actually go onto the website and you can search to see where providers are closest to you that can create these welcoming and inclusive environments. So that is one way to make sure, that you feel more comfortable. And I mean, the other one is we're trying to work on it. We're trying to train providers to be more knowledgeable about the needs of the LGBTQ community so that we can create that welcoming and inclusive environment, because people shouldn't be afraid. I'm not afraid to fill out my form, and someone who's LGBTQ, me as an ally, we should both have the same amount of fear, right? It shouldn't be different. And I understand why. Same reason, a lot of people are afraid to share certain information. Sometimes I'm not the most honest with my doctor because he might get mad at me, even though I should be. Maybe I lie about how much sugar I consume or things like that. If I do eat those 5 servings of fruits and vegetables. But I think the number one thing that we need to make sure as healthcare providers that we're providing an inclusive environment in order to make it more welcoming. But then as patients, you can look up providers that have created those environments by looking them up. Or I'm sure the LA LGBT Center or other centers have a list of providers, but I do know City of Hope is one of those. And we're judged by not just how we treat patients and family, but also our employees. That's how the index works.
Yeah, absolutely. Thank you for answering that. And I think it's important, to be able to advocate for yourself, but even more so for the healthcare community to kind of change the culture around the conversation and making sure that it's comfortable for all. So thank you for that. It looks like we don't have any more questions for today. Thank you so much for being here and for providing this information. It was such a pleasure to have you. And hopefully,
thank you for having me. And like I mentioned, I have my email. Feel free to reach out if maybe you weren't comfortable asking the question here. I'm more than happy to take your question online. You feel free to email me.
Wonderful. And if you are interested in the PowerPoint that Mayra is so kindly sharing, please feel free to email info@cancersupportla.org. I'm also going to be putting that into the chat room right now. Feel free to email us and reach out. And thank you so much, Mayra. We hope to see you again soon.
Thank you so much. Bye.